Episode 37, Knee Pain After a Twisting Injury. Welcome to Sports Medicine Case Studies, where I review published case studies, provide key takeaways, and a few practice questions. Our case today is a 22-year-old male soccer player who presented to the emergency department with acute left knee pain. He was running during a match, stopped abruptly, and pivoted, turning his upper body and upper leg while his foot stayed planted on the ground. When evaluated in the emergency department, vital signs were normal and there were no other complaints besides the knee pain. The inspection demonstrated an abnormal knee contour with an anterolateral prominence just below the knee. Evaluation of his pedal pulses demonstrated strong and palpable pulses. Sensation below the knee was intact, and range of motion and ligamentous stability testing were deferred initially due to pain. The popliteal fossa was not palpated. So my differential on hearing this is substantial ligament injury, fracture, or potential knee dislocation. I want to recognize the authors. This case report was published in Case Reports in Emergency Medicine by Douma, Burg, and Dijkstra in 2017. I am Scott Hollis, primary care sports medicine physician, and I am studying for my sports medicine certification exam in 2026, and I hope you will join me on the journey. This podcast is for educational purposes only. Radiographs confirm the diagnosis: a rotary anterolateral knee dislocation without fracture. This is a relatively uncommon subtype of knee dislocations. Most knee dislocations are anterior in direction. The physicians performed a successful closed reduction under procedural sedation. Immediately after reduction, they obtained an ultrasound of the popliteal fossa, which showed normal arterial and venous patency with no vessel wall irregularities. There were also no hematomas identified. CT angiography was not performed. An inpatient MRI revealed a bucket handle tear of the lateral meniscus plus tears of both the medial collateral ligament and the anterior cruciate ligament. Surgically, a staged approach was elected. First, arthroscopic MCL reattachment with partial medial and lateral meniscectomy was performed. Then, 4 months later, a hamstring autograft was used for an ACL reconstruction. The patient recovered uneventfully. Couple of key takeaways. Acute knee dislocation is a potentially limb-threatening injury defined by complete displacement of the tibiofemoral articulation. It involves disruption of at least two major knee ligaments and carries a significant risk of popliteal artery injury, with recent literature estimating between 10 and 18%, and peroneal nerve injury, with the percentage there approximately 20 to 25%. Approximately 50% of knee dislocations spontaneously reduced before emergency department evaluation, making this a diagnosis one should have a high index of suspicion, particularly in any patient presenting with knee pain after significant trauma. Most cases result from high energy trauma, typically motor vehicle accidents, falls from height, or athletic injuries. An increasingly recognized subset is ultra-low velocity knee dislocations occur mostly in obese individuals after simple falls and carry an increased risk of inferior outcomes. In terms of demographics, males predominate at about 80% of these injuries, with a median age of approximately 35 years old. Anterior dislocations are the most common subtype and involve hyperextension and a high risk of popliteal artery and tibial nerve injury. Posterior dislocations are typically dashboard injuries and have a vascular index rate that the literature estimates at 25 to 30%. Lateral dislocations, which involve a varus force, have an extremely high risk of common peroneal nerve injuries. When one sees a knee dislocation, the immediate priority is prompt closed reduction, followed by a systematic vascular assessment. Most of the following information is from Reference 1, which was a very recent review of knee dislocations. The first step is to reduce the dislocation, typically with longitudinal traction with correction of the deformity. If the reduction cannot be performed by closed means, one can proceed with emergent open reduction. This is usually secondary to buttonholing of the medial femoral condyle through the capsule or interposition of soft tissue, preventing a closed reduction. Second step involves a vascular assessment, which is the crucial step after reduction. One should perform a thorough pulse examination, including the dorsalis pedis and posterior tibial pulse, and measure the ankle brachial index. An ankle brachial index that is greater than or equal to 0.9 with palpable symmetrical pulses. If this is confirmed, one can observe with serial neurovascular exams to detect delayed vascular compromise or compartment syndrome. If the ankle brachial index is less than 0.9 or asymmetric or diminished, obtain CT angiography urgently. Absent pulses or hard signs of ischemia, including expanding hematoma, pulsatile bleeding, and distal ischemia, require emergent vascular evaluation and surgical consultation. One should not delay for imaging in these situations. Once the knee has been reduced and a vascular evaluation has taken place, typically treatment can involve application of a knee immobilizer or a hinge brace at about 20 degrees of flexion. External fixation is indicated if reduction cannot be maintained in the setting of open wounds, associated fractures, or when vascular repair is needed. Regarding the neurologic examination, one should document perineal and tibial nerve function, including exploration of foot dorsiflexion, plantar flexion, and sensation. This neurovascular evaluation should be done at presentation and serially. For imaging, obtain initial radiographs to confirm the diagnosis and subsequent reduction and to identify any additional fractures. An MRI is typically deferred until after the acute evaluation to define the full extent of ligamentous, meniscal, and chondral injuries. Okay, questions. A 22-year-old male soccer player presents to the emergency department with acute left knee pain after a twisting injury. Radiographs confirm an anterolateral knee dislocation. Successful closed reduction is performed. On post-reduction evaluation, pedal pulses are palpable and symmetric bilaterally. Here's the question. What is the reported incidence of vascular injury after knee dislocation? Answer. The reported incidence of vascular injury ranges from about 7 to 64% depending on the dislocation type and mechanism, with popliteal artery injury specifically reported in 32 to 45% in older studies, though more recent meta-analyses report overall rates of approximately 11 to 18%. Question 2. Why is the popliteal artery injury particularly dangerous in this setting? A popliteal artery injury is particularly dangerous because collateral circulation around the popliteal artery is poor in most patients, insufficient to sustain distal limb viability long term, yet robust enough to deliver temporarily palpable pulses, even with a popliteal artery transection. Historical data demonstrate an 86% amputation rate if devascularization persists for more than 8 hours. Okay, question 3. Describe the selective angiography protocol for vascular assessment after knee dislocation, including the role of ankle brachial index and the critical threshold value. Okay, the selective angiography protocol proceeds as follows. One should do an initial examination looking for hard signs of vascular injury, including absent pulses, expanding hematoma, and pulsatile hemorrhage. If identified, one should proceed to immediate surgical exploration with intraoperative angiography. If no hard signs are present, perform bilateral pulse examination and measure the ankle brachial index. With an ankle brachial index less than 0.9 or asymmetrical pulses, proceed to arteriography or CT angiography. If an ankle brachial index is greater than or equal to 0.9 with normal symmetric pulses, one should admit with serial vascular examination and frequent pulse checks. The critical ankle brachial index threshold is 0.9. Studies have demonstrated that a combination of palpable dorsalis pedis and posterior tibial pulses with an ankle brachial index greater than or equal to 0.9 has a 100% sensitivity for excluding significant vascular injury. CTA has largely replaced conventional angiography as the preferred advanced imaging modality at most centers due to its superior accuracy, lower invasiveness, and greater time efficiency. Thank you.